Thank you, each of you, for making this FERTYGNAN Vijayawada grand success. So, I understand the session is in between you and lunch, but please bear with me. I'll try to be as fast as possible. So, the urge of parenthood, it's not new. It's there since ages. On Chaitra Paksha Shukla Masa, trillions of years ago, 5114 BC, Lord Rama was born. Rama was born. Dashratha himself performed something called as Putra Kameshti Yajna. So it's not new. It's there since ages. This sir is Robert Fisher, sir. He is a very pioneer in the field of fertility. I think all my friends know him as well. So when I started my fertility practice 20 years ago, I used to read a lot of his books and something I could not understand as well. I wanted to go talk to him and ask him many questions, unanswered questions. It was very tough then. Every time we go to Ishray, sit with him, ask him some question. So life was then. But now, if you see this slide, couple of months back in our every Wednesday journal club we had luxury of having him as a speaker, and he answered all of our 22 consultants query. So where are we now? Thanks to the digital platform. Just by a click of button we can talk to people and ask questions. Yeah. Now if you see this, in my childhood, when I was just 10 years, I'm not getting this video. Yeah, Star Trek. Okay, this video is not playing. I got a video of Star Trek. When I was 10 years old, this was a very popular TV serial then. Every Thursday we used to wait for this at 5:30. When is Thursday happening? So then, in here it was like, Star Trek with a Spock and a captain. So whenever the Spock comes, he just presses a button and he can see people somewhere outside, somewhere, wherever it is. So I used to wonder, is it real? Can it ever happen? Can we see our friends who are somewhere on face? But then, of course,
moving on schedule in quadrant 904.
That's what it was then. Now you see, you all have watched this popular movie in Telugu, Maya Bazar. Maya Bazar, Dwapara Yuga, Krishna had already FaceTime, WhatsApp video call, everything. He just used to open and used to talk. So whatever we see, recent advances are already existing in the past. We are just finding out what was there in the past and we are repeating it now. So about fertility, if you say, what is fertility? What are the advances? I'm talking about advances in the fertility. Can we achieve this magic number 100? Is it possible? When we started the journey, when Louis Born was born, then IVF success rate was very less. Maybe less than 15%. But 2000 it was almost 35. And now where do we stand? 2024, it's nearing 60s percentage, 60, 65. So that is something changed, right? Everybody wants, when they come to a doctor, they want to conceive. Somewhere recent advances are important, how we are progressing, to hopefully we should again put one dream now that magic number should be achievable, but it's definitely not so easy. Yeah. So I will talk first about little guidelines, little technology and little techniques. If you see the guidelines, I won't be talking what was in the past. We all know about PCOS. This new guidelines which has come in 2023, the last year. How is it different from Rotterdam's, which was in 2006? We all know Rotterdam's, we are aware about Rotterdam's. 2 out of 3 criteria, right? PCO 12 is the number. How is this different from the recent guideline? These are only 2 ideas I am putting in your mind. Here they have given very beautiful algorithm, the way you screen a woman of PCOS. There are 3 steps. What is the first step? First step is similar to the Rotterdam's. You see a woman with irregular cycles, and if she has hyperandrogenism in clinical, like you can just by seeing the women, you can see all the unwanted hair, hirsutism, all these. So you don't even have to do a scan. Don't ever go and do a scan. You understand? She is PCOS. Now say suppose woman has irregular cycles. She doesn't have any androgen symptoms. She is just come sitting in front of you. I have irregular cycles. No hyperandrogen clinically. Then second step is do a biochemical test. And then you diagnose. Okay, done. Now, if at all women comes with only irregular cycles, without even clinic and biochemical, then or a woman come with only hyperandrogenism, then go to the step 3, that is you do a scan. So scan has been dragged towards last now. Why did they do this? See, any advances, they want to do good to the society. Previous Rotterdam, what was happening? Every sonologist used to do scan 14, 15 follicles, PCOS. Pandemic of PCOS we started seeing. Now how to eradicate this pandemic of PCOS? So all the societies, if you see here, 3,000 healthcare professionals sat together and then 1,000 multidisciplinary clinics. With all this they came to this guidelines. And then other very interesting here is also the number of follicles they have changed here. We have to know about something called as FNPO, follicular number per ovary. It is more than 20 now, not 12. So just by doing this slight change, most of the non-PCOS people are out of the PCOS diagnosis. So this is very important. The second is another called as FNPS, follicular number per section. In one section you see 10 follicles, you can, but this is only step 3. It is not the step 1 and 2. And then of course, what about serum AMH? Either before AMH was never as a diagnostic criteria. Now as a step 3, they have even used either scan or an AMH for a adult women. But for adolescent PCOS, please don't do AMH and categorize her as PCOS. Very, very clear. So this is very simple. Look at this ovary, but just by seeing this, but you have to scroll from one end to the other end slowly and count the numbers. More than 20 in scan PCOM morphology. This is about PCOS. I am not going in detail. Just the diagnostic criteria, what is in the recent. Next is about, if you see about endometriosis. Just 2 words about endometriosis. Now we all know before, what was the gold standard in diagnosing endometriosis? Laparoscopy. I think now it is changed. The gold standard is not for diagnostic. Vinny, I can be very, because she's a surgeon and she's totally into endometriosis. Now I'm not telling about treatment. For diagnosing endometriosis, gold standard is no more laparoscopy. You can do this something called as idea consensus. There is this consensus of idea consensus where they have given again 4 steps to diagnose endometriosis. Very simple it is. First when I saw these 4 steps, I was wondering what are these 4 steps. But it is the way you do a scan. First step is, just I will put the video, I have a video here. So first is you take your probe, just go and see the scan. In the scan, you may see some adenomyosis. And then just scroll and then go to both the ovaries. Ovaries, when you see, if at all you see a endometriosis cyst, yes, that is the step 1. Then second step is, again find out, go and then see if there is any pain. She has to, and the mobility of the ovaries. Most of the time, if severe endometriosis, there will be adhesion and the ovaries are immobile. And then next, third step is do a sliding sign. Very easy. The bowel usually is free. Posteriorly, it won't be attached. But in endometriosis, you do the sliding sign. You see the bowel won't slide away. Here I have this video with a sliding sign where you just put it to the posterior fornix and just slide it. And then usually in this you can see the bowel and the ovary is attached to the posterior and it's not sliding. So most of the time, sliding sign positive or negative, people ask. Positive means it's normal ovary. Sliding sign negative is endometriosis because it has to slide away. And then fourth step is to see any nodules. So these are the 4 steps along with clinical history, like all the D's no dyspareunia, dysmenorrhea, dysuria, with history and with this idea consensus, you can diagnose endometriosis. Laparoscopy is no more a gold standard to diagnose endometriosis. That something has changed in the guidelines. Yeah, this is how we demonstrate a sliding sign. See, for some endometriosis, do you have to do all the, it's such a huge endometriosis, you don't even, by just look of it, you can diagnose this. And then, if say suppose you are posting the women for a surgery, I'm not here to debate between surgery and IVF now, I'm just enlightening you about EFI, very important. Say suppose you have posted the women for laparoscopy because she has pain, or she has other issues, then have this chart, very important, EFI, Endometriosis Fertility Index Score. See, most of the time what happens, you call surgeon, you are seeing OPD. Surgeon does something and he goes away. You should know the relation of the ovary. You should know the relation of the tubo-ovarian mass, how much percentage of adhesion, along with that historical factors like age, duration, infertility, and they give a score, 0 to 10. Score 0 is the poorest prognosis. Score 10 is the best prognosis. Where, after doing this, you can act like a palmist to her. Her fertility index, you can tell her how much time she has to conceive. Next, I want to know by the rise of hands, how many of you do 3D ultrasound? Today I will urge most of them, after going back, just upgrade your scan and it's very wonderful. Initially, I'll tell you, I am a person who usually don't like so much change in the life. But then, once change, initially it is always difficult. In between it is messy. But once you change, no, it is something beyond. So, please try to incorporate 3D in your daily routine whenever you are using. See, this looks a polyp. But then, the polyp here in the sonography, it looks like this, saline sonography. But you do 3D, see where the polyp is sitting, just at the point where the fallopian tube cornu. Just knock off this polyp, definitely natural conception chance is very high. And this woman, she came to us for IVF cycles. Repeatedly we were doing FET, we put lot of estrogens to prepare the soil. After 4-5 cycles, we used all the type of FET protocol. She failed. Endometrium never came up. Then just one 3D, we understood it's a unicornuate uterus. There is some shape abnormality. How much ever estrogen I dump, this endometrium won't come. So very important to understand 3D also. And then look at this, how nicely it is seen, communicating, non-communicating horn. And this, what is the finding here? Anybody can tell me in HSG? Very spot diagnosis, MCQ question. Unicornuate uterus. Fine. But then when we did a 3D, it's not a unicornuate. It's a normal uterus because of adhesions. One of the side is already, there is adhesions here. So just releasing adhesion helped her a lot. So that is the importance of 3D. So till now, I have told you what all is existing. But now I will tell you something which are in experimental, because we should know where fertility is going to. There is something called as SOET, self-operated endovaginal telemonitoring. You know how the advancement is going? You don't even need a gynecologist to do a scan. You give a probe to her at home. She will have a small probe. She'll insert into the vagina, and then now there is the smartphone. She'll connect it to the smartphone, and you sitting in the clinic, you can see her scan. But I should caution here, I think Dr. Hitesh sir will be talking about law. PCP and DT, he'll come and hold our neck. That is a different issue. We'll wait for that. Of course, there will be some censoring happening later, but this is what, because one of the company of ultrasound even approached us. They wanted a lot of data, but then we thought we'll ask our legal advisor and then sign that contract. Things are there, so much change is happening. And then what about male infertility? About male, even people who, sperm test also FDA approved. It was already launched in India. They don't have to come to center. They can do a test like LH kit, put their sperm, and with the smartphone it will read. But again now, because of ART rules and regulations, I don't know where this technology will go and lead to. Now, next is artificial intelligence, something really bothering me sometime, but of course we have to encourage some things. See, this is a mother, a family teaching kids. We teach kids, we tell this is apple, this is orange, that's how they learn. This is called as a not supervised learning, but when it comes to, that is human learning. When it comes to machine learning, it's a supervised learning. They put a machine, they get all scans and feed it to the machine. They get all data and feed it to the machine. And the machine learning, though it is monotonous, it can learn many things at a time. And it is a supervised learning. That is what artificial intelligence is. And then if you see, mostly more than fertility industry, it will hit the sonologists now. Because so much is happening in artificial intelligence. All my daughter's friends, whomever we ask, when our time it was medicine or engineering, we used to take path. But now anybody you ask youngster, I'm in AI, I don't know what all these people are up to, where are they going? Yeah.
I have a point to make.
Yeah.
The patients are very smart.
Yeah.
I had a patient whose husband didn't want a child, but she wanted.
Okay.
And there was a lot of this thing. And that guy used to use condoms regularly. It's very interesting. So this lady, what she used to do, that packed condom, she take a needle and that with the needle. So she pokes that with the needle. So the condom becomes, damaged. And then that guy, I think they used to switch off lights and then do it. So that those damaged condoms, and that lady conceived. And after that, that guy, they came to me. They said, I use condoms. How did she conceive? So he started, doubting, suspicion. So then comes the role of counseling. That's what I want to tell.
I will take her story one more ahead. See, I usually tell patient to try naturally. Whatever IVF failed also, I tell you try naturally. So it so happened, one lady with azoospermia, she became pregnant. So as a doctor, I am in a spot. What should I tell? I just told her, I don't know, sometime it may happen. You don't have to dig inside, It's enough for the day.
Waxing and waning counts, that's your,
Yeah.
you have to tell. It can go up and down types.
Exactly. Yeah. So now, after pickup, even they can choose which is the best oocyte. It seems AI will choose. I think even in our center, we are launching AI maybe in a couple of months, and that will select sperms as well. And embryos also it will choose. Now, I was telling our people, let AI do ET also. Why are we here? And when beta HCG fails, let them talk. Because most tricky is when it fails, sitting in front of patients and telling what happened. See, end of the day, wherever AI goes, clinical touch, human touch is of value. I somehow feel coming into this fertility field, we have become more spiritual. You take 20x, 10 years before, you store that, she becomes pregnant. After 5 years, she comes back again for second set of embryos, 10 years before pickup. Again, life sets in. You don't even know when the life set in. So much is about human touch is very important in any field we choose. And there about antioxidant, there is something coming called as ROS analyzers. You don't have to repeatedly give antioxidants. There is a test which says how much antioxidants has to be given. RA witness is something where gamete mismatch we can prevent. We have launched in our system where human error is 0. There is a barcode. We give it to every patient, and then once they put the barcode, only if there is any little mismatch, there is lot of alarm. So there is no way where we can have a gamete mismatch. So this is something called as we have also adapted to this new technology. And of course, in my inaugural, I have told about the Ziltrix. Ziltrix is something where you keep your embryos inside the lab, and when you go home, the baby has to be in a safe place. If there is any power fluctuation, this gives alarm to the system, and then we can immediately act. So the embryos are very safe. What about PGTA, PGT, all these exist, So many times it so happens, we should know when to use the advanced technology as well. And now there is something new. All my videos are not working. I'm very sorry. I got a lot of videos. So here this is something called as microfluidic chip. This I just wanted to enlighten you on. For IUI we need all the centrifuge, right? No, there is a chip. It's just like a visiting card. It has an inlet and an outlet. You put the raw sperm, process to the inlet. Half an hour you put in the incubator. After half an hour you get the processed sperm. So this is some game changer. But then again ART law wants the 4 apparatus when you come to give your licensing. That is a different part. But this is now we are using it whenever there is high DFI and there is male infertility within IUI and ICSI as well. It has definitely given little better success rate. Yeah. And then gene editing. So if some patients come to you and ask, doc, I have my wife with BRCA, I don't want my kids to have similar breast cancer. There is something called as gene editing. So these are all the advances. There is a technology called as CRISPR technology where they edit a part of the gene and then a pregnancy can happen. The babies should be safe. So what about the designer babies? You know, most of the time they used to think fertility is all designer babies. Please, we are very far from that, especially of this. After this ART rules and regulation, getting a donor is so tough. It's not at all easy. Getting a donor egg, donor sperm has become very tough. Forget about designer babies. It is, the reality is different. And then here, if advanced technology goes to a different hand and if there is a designer baby, women always want more. They don't settle in less. Already I have got a designer baby. Next what? Let me have a designer husband. Let me see my luck in that. We never know where this stops. And then these are so many technologies. So I think Dr. Suma has covered about all these. I will just skip through PRPs. So ectogenesis, we all know. Now we don't need a woman also. Baby is outside the womb. What about, in our Mahabharata? That time itself all the surrogacy pots existed. Yeah. And then they say they can do a baby in the skin also, from skin. So if you see in our, Ganesh was born through skin itself. She took all her sweat and she made. So it was already existing then. So future of AI should be in the hands of Rama. It should not go to the hands of Ravana. It can lead somewhere. So some people should work on censoring what is not correct for the day. So I end my presentation with this, clinical touch is very, very important, very mandatory. Whatever AI comes, human will be there, human will exist and control this. To end it, I had got a magic carpet. I was talking to Dr. Padmaja. This is some, in Alauddin Khilji movie, Alauddin, she has a magic carpet, Coming to Vijayawada was so difficult. Long time back, I had put a dream of seeing, FaceTime has come now. So one magic carpet where the hero takes the heroine and shows the whole world. So hopefully days should come true when we all have a magic carpet and our travel time decreases. Thank you so much. Thank you.